Good morning. I am Dr. Jyothi, presenting our initial experience with the polyfocal IOL. Cataract surgery in recent times has evolved from a purely disease-correcting treatment to a elective refractive procedure, increasing visual quality and reducing spectacle dependence. Presbyopia-correcting IOLs are designed with diffractive, refractive, or combined diffractive-refractive optics. Depending on the light distribution across various focal points, they can be bifocal, trifocal, extended depth of focus, or continuous range of vision lenses. The traditional IOLs have rings, and because of these rings, they split the incoming light into different foci, which results in reduced contrast sensitivity postoperatively. Also, the stray light entering between these rings increase the incidence of glares and halos. Rotationally asymmetric refractive IOLs were developed to eliminate these rings. The Spirant Autofocus Pro IOL is a rotationally asymmetric refractive IOL using the gradient refractive index concept. Since this is a newer IOL in the market, very few studies have been done on the outcome of this IOL. So this study was designed as a pilot study to analyze our experience with this polyfocal IOL. The aim is to evaluate the visual outcomes in patients undergoing cataract extraction and polyfocal IOL implantation. It was a retrospective observation study conducted from February 2021 to May 2025 in patients undergoing cataract extraction and polyfocal IOL implantation in our center. Preoperatively, the demographic details, type of cataract, IOL power, distance and near visual acuity in logMAR and keratometry were done. The IOL power was calculated using Barrett's Universal 2 formula or SRKT formula. All patients underwent standard phacoemulsification under topical anesthesia, and postoperatively topical antibiotics and corticosteroids were given. At 1 month postoperative visit, the patient was inquired relating to symptoms of glare, halos, and overall quality of vision. The distance and near visual acuity was tested. The depth of focus assessment was done, and routine slit lamp examination was done. All obtained data were analyzed using Microsoft Excel. We evaluated 30 eyes of 19 patients. The mean preoperative visual acuity was 0.93 in logMAR. Postoperatively, 90% of patients achieved a visual acuity of 0.3 or greater. There was no negative dysphotopsia, glare, or halos. The mean visual acuity at -1 diopter defocus was 0.22, and at -1.5 diopter defocus was 0.25. Diffractive IOLs are based on the principle of diffraction, where light slows and changes direction upon encountering an obstacle. The zonal refractive IOLs have typically two distinct powers incorporated into two or more circular refractive rings. The hybrid diffractive refractive lenses utilize both these principles. The rotationally asymmetric multifocal IOLs have two or more segments with different distinct refractive indexes. The aspheric transition between these segments redirects the incident light away from the optical axis, preventing blurred vision from interference and diffraction. Accommodating IOLs use ciliary muscle contraction, capsular bag elasticity, and changes in vitreous cavity pressure to induce change or movement in the shape of IOL. The hinge between the optic and haptics allow the lens to move forwards during near vision and backwards during distant vision. The gradient refractive index lens, the refractive index varies across its volume, enabling a smooth bend of light rays. The smooth optical surface decreases the possibility of mechanical damage to the lens optic surface. It is pupil independent and provides a better retinal image quality postoperatively. The Spirant Autofocus Pro is a foldable single-piece hydrophobic acrylic IOL consisting of 60% hydrophobic and 40% hydrophilic material. It has an oval optic of 6 mm and a 1.5 mm plain collar around the optic with a haptic size of 5.5 mm, making the total dimension 13 mm. It has a characteristic L-loop haptic with zigzag serrated edges with a vertical length of 6 mm. It has a double ring square edge to reduce the incidence of posterior capsular opacity. It has two dialing holes, 300 microns in size, which are to be oriented superiorly and which also aid in viscoelastic outflow to the anterior chamber. The refractive index varies from 1.42 to 1.52 with an average of 1.46, and it is made of UV absorbing material. The anterior side of the optic is divided into three zones. Zone 1, the superior zone, 180 to 200 degree is for far distance. Zone 2 is for intermediate distance, and zone 3 is for near distance, with add of 1.5 to 2 diopter for zone 2. The posterior side of the lens has an aspheric design. The power range is from +3 to +40 diopter with a theoretical A constant of 118.5. The zigzag L loop provides higher friction and solid rotation stability due to the higher contact with the posterior capsule. In our study, it provided good near vision of 80% unaided N6, which is similar to the study by Moria et al., where 71.6 patients had N6 unaided. In the study by Moria et al., 104 subjects were evaluated, and it was found that the reading speed and contrast sensitivity were significantly superior in the autofocus pro group compared to the traditional diffractive refractive IOL. In our study, none of the patients had photopic effects which are similar to the results in Moria et al. 3 patients had distant visual acuity of less than 0.5. All these 3 patients have cylindrical refractive power of more than 1 diopter. This is one of the disadvantages of this IOL, that toric correction cannot be incorporated. One of our patients had a postoperative IOL rotation of 45 degree. Still, the patient had distance visual acuity of 0.04 and near visual acuity of N6, which shows that the lens is very forgiving. The limitations of our study include lack of control group and very small sample size. Further randomized trials are required to study the effectiveness of this lens and compare it with the multifocal IOLs. To conclude, polyfocal IOLs provide good distance as well as near vision with an added advantage of reduced incidence of glare and halos and cost effectiveness. Thank you.
Thank you, Jyothi. Yes, this is the new device. If this has been tested in animal or cell-based study for its safety?
There was an optical bend study, sir, and this study by Arvind Moria is the only other study which was published in 2025.
Study on human eyes, right?
Yes.
So, what the rule says when you're introducing a new device, because this is a new device, you are mixing hydrophobic and hydrophilic material. So, has the safety and complications of this device in human eyes or possible complication have been tested in any animal models or any experimental studies? Because without that, it's not practical to trial this lens in human eyes. That is what the standard norm suggests.
I'm not aware of the animal studies, sir.
Please go through that, because if you launch any new device, right? Even if it's a IOL, but if it has any difference in its composition, that has to be first tested for safety. Okay, that is what is a phase 1 study suggests. Once your phase 1 trial is done, then this is phase 2 study where you are just looking for whether it is efficacious or not. Then comes your phase 3 where you will do a randomized trial with a control, one established gold standard IOL. Okay. So anyway, nice study. And you said sample size is small. What was the sample size?
30 eyes, sir. 19 patients.
19 patient, 30 eyes.
Regarding lens design, bifocal segment is 90 degrees. It's very straight, but usually in bifocal or progressive lens, even the thing, they should follow the bifocal fitting of the lens, IPD, according to the IPD. Did they explain about the lens design? Because the nearest segment is almost 90 degree.
That is horizontal.
Horizontal, no, it is the vertical arches, I am telling. The near vision, if you put that picture, I'll show you. It's almost 90 degree. They have not bifocal segment, the near segment. 3 segment, but at the 90 degree it is there. No, when your near vision comes, the eye will be in convergence. But here it is the designing. I am not reflexes. In progressive lenses, the same this different on this. That has to be explained because then IOL design is very, very important according to pupil size.
It's pupil independent.
Pupil independent.
Did you check aberrations with this IOL?
Sorry, sir?
Aberrations, higher order aberrations.
No.
So that will be good information if you do it, because when you make transition zones, we give progressive spectacles also, and there is a component of neuroadaptation to that. And few cases they never could accept progressive spectacles because they
For
couldn't
this
adjust.
IOL also, there was a slight neuroadaptation period of around 1 month. in the first week, most of the patients were a bit unhappy. Then at 1 month, they were very comfortable.
But if you check for higher order aberration, that will give you more information what sir is asking.
This as well. You need to look at late onset complications, right? See, the thing is the bag contracts. That's with every IOL that you put in. This one has a problem in the sense that if you have capsular phimosis and if the IOL crumples or if it folds, the effect is gone. In fact, it creates a negative effect. Patient loses not just near, patient loses distance as well. So we've had patients in whom, I mean, Dr. Moria himself has said that patients have had, horrible post-operative surprises. Very few in late onset, especially when you're putting them in young patients. Right? Photopic phenomenon is different, but then please look at the late onset. Follow these patients up over the course of the next 1-2 years. You do have some patients who have intense, capsular phimosis that happens. Please look at those patients as well. Yeah? Good
Thank you.
presentation.